authored by Ms. Ritu Ghosh and Ms. R. Surya. Ms. Ritu Ghosh is the Academic Director of Mobility India, and it will be presented by RCI certified prosthetist and orthotist, Ms. R. Surya. Let's welcome her on the stage with a big round of applause.
Good afternoon, one and all who are present here. Myself, Surya. I'm MPO final year student. I'm thankful to the platform who have provided me an opportunity to present my dissertation topic over here. And my guide is Ritu Ghosh. And the next is Vanilla ma'am. In my topic are barriers experienced on the usage of walking aids in an older adult in the home environment, a cross-sectional study. Introduction. According to the WHO 2011, around the world, there is 90% of the disabled elderly populations in globally. According to the 2011 India census, 1 out of every 20 Indian people aged 60 and up is physically or intellectually handicapped. To understanding how the psychological and physical aspect of the home environment are linked to the use of a walking device is crucial, especially at a time when human assistance is expected to become scarce. And the objectives of my studies, the primary objectives of my studies are to investigate the barriers of older adults using walking aids in the home environment. And my secondary objectives are whether the social factor affecting the use of walking aids or the psychological factors will affect the usage of walking aids or the physical factors will affect the use of walking aids. So, and my methodologies are the study design. I have conducted cross-sectional study design, and my subject is who were older adults 60 and above, and my sample sizes are 40 samples. And my study is centered in both Vellore and Bangalore. Source of data I have collected from the old age home as well as in the individual home visit. Sampling method, I have chosen a non-probability sampling method, which is a convenient sampling method, and my study duration is around 6 months. Here I have chosen a mixed method of study, which consists of both qualitative and qualitative data. Sample selections. Inclusion criteria. The study involves the age older than 60 years and frequently using a walking stick and an assistive devices such as single cane stick, single tip cane, forearm crutch, and walker. And my exclusion criteria are severe neurological conditions and severe orthopedic conditions, and severe cognitive impairment, visual and auditory control. Temporary usage of walking aids. So these are the exclusion criteria of my studies. Methodology. I have collected data from May to June, and I have conducted a face-to-face interview. The time taken by the respondents to answer my question, including my outcome measures, it takes around 25 to 35 minutes each samples. Data were documented in an audio recorder as well as in a written document. And my data analysis I was done with the R software version 4.01 was used to analyze to collect the data after entering them into a master spreadsheet. So from there, I have did a mean and standard deviation of my study. The independent t-test was performed for the demographic data and chi-square for my categorical variables. And my results are quantitative analysis. So as I mentioned previously, my study has both mixed method, both qualitative and quantitative. First, we will discuss about the quantitative analysis. For in older adults, the main causes is medical conditions. Here you can see there is a 17.5% of the hyperextension. Only the hyperextension, the older adults who were facing the medical problems. So here I have considered some of the medical conditions, single as well as a combined medical conditions, and psychological factors. due to the aging of the adults, they were becoming a depression. So here I also calculated the psychological factor, consider a psychological factor. Here you can see the moderate level of the depression is around 35 percentage and severe depression is 32.5 percentage of my total samples. So I have get among the three barriers, social, psychological, and physical, I have get some significant values in physical factors. Here I have mentioned some of the physical factors which is significant, which has a significant level. The one is the distance, how long they walk in their home, because I have considered a home environment. So I have considered a distance in the home and walk within the home, how many minutes, and whether they are managing their steps or stairs. So here, these are my significant values, and my significant values is less than 0.05. Now I'm going to talk about the qualitative analysis. From the collected data, I have categorized into three categories. One is the acceptance of walking aids, next is stigma, and the user instruction. The acceptance of walking aids in the older adults, it is basically no one were aware of the physician to consider whether to use the which kind of walking aids have to use. So most of them were purchased from the camp and get suggestion from the others. For example, they get suggestion from the relations, suggestion from the friends. So they are not suggest the physician to get the walking aids. And the stigma. The stigma is some of them felt depressed upon realizing they required assistance with mobility, making it difficult for them to accept the situation right away. And the user instruction, if we can't, if we lack provide in the training, so these things will happen. One is the postural deformity and other complications will arrive. Already they were in depression, so this will also included for the burden. Increasing physician awareness of the need for walking aid use and their role in making prescription referrals. Exposure to peer role models giving customers a choice of equipment style and design and production safe, low impact walking aids. So here we have to follow the educate them, and we have to give a choice to find to select the equipment tools. And discussion. The current study suggests that social stigma, working aid provision, education training, and adaptations are the key phases that influence older people's use of working aid. In discussion, consider a social factor in order to improve older adults' life circumstance, integration into senior housing, family members' motivation, and support are unquestionably crucial. And physical deformities, as I mentioned, the medical factor is the first barrier for the older adults. So we have to take care of this and as well as the environment. And conclusion of my study is it is important to focus on the physical difficulties of home. The user is not aware of the need and benefits of walking aids. Service providers could consider offering to educate their clients on the need and benefits of walking aid as well as a choice of various types of product considering the home environment and social factor. So here the main thing is we need to give them awareness but through the physician and educated them about the walking aids, and we have to give a selection, choice of selection. The future recommendation of the studies are should investigate the linkages to determine the mechanisms underlying them and consequently how we might create opportunities for upcoming elder generations successfully integrate into the community. For example, we can modify in a house itself to overcome the home environment barriers. So these are my references. Thank you.
Thank you, Ms. Surya, for your wonderful presentation. Next, I'd like to request the audience to ask any questions if they have. Thank you, Ms. Surya. Next, I'd like to invite our next presenter. Our next presentation is titled Modified Transfemoral Socket for Volume Adjustment and Mediolateral Stability in Transfemoral Amputees with Diabetics, a pilot study. It is authored by Mr. Jibanjit Mohanty, an RCI certified prosthetist and orthotist, Mr. Guru M. Mr. Jibanjit is Assistant Professor P&O at Mobility India, and it will be presented by Mr. Guru M. Let's welcome him with a big round of applause.
Good afternoon to one and all present here. I would like to thank Mobility India for giving me this opportunity to present the topic. Um, Today we'll be talking about the modified transfemoral socket for volume adjustment and medial lateral stability in transfemoral amputee with diabetes, a pilot study. So my guide is Mr. Rajiv Kumar, and co-guide is Mr. Jibanjit sir. Moving on to the introduction part, the most common seen cause of amputation in transfemoral users are due to trauma and diabetes. Post-operative prosthetic management comes with certain complication, and one such major complication faced in transfemoral amputee is the limb volume fluctuation. Currently, there are many commercial transfemoral socket technology available in the market, which helps in limb volume adjustability, but does not provide any evidence based on the comfort and stability of the socket, nor incorporate a simple mechanism for providing quick and easy adjustability. For the issues which leads to increased risk of prosthetic abandonment, and therefore a prototype model was designed to test for socket fit, stability, and to incorporate a mechanism for quick volume adjustability. So basically, my study was to get a good volume adjustable socket, which is non-subischial, because usually currently, if you see, like many sockets are based on subischial designs. And through this, I wanted to achieve the skeletal ML stability, and also incorporate a quick mechanism for the patient himself to handle the adjustable feature of the socket. So methodology, study design, it is a single case pilot study, and study subject diabetic transfemoral amputee, and sample size is 1. And study setting was done in working premises of Mobility India. And sampling method is purposive sampling. And study duration was for 10 months. And tests that has been performed were L-test and socket comfort score. So the inclusion criteria for my study was transfemoral amputee with differential stump volume, mainly like diabetic users, and a prosthetic user for more than a year, and age group of 45 to 64 years of age. And exclusion criteria was cause of amputation other than diabetic, cause of stump volume fluctuation other than diabetic, and age group below 45 and above 64 years of age. This is the flow chart of how my data was being collected and how my study was proceeded. And this is the prototype one model, which is having the ratchet dial system, and is having a single cutout. It is a bi-walled socket. So before taking any information of the patient consent was taken, and all the ethical consideration was being followed. And for this patient safety, there was like 2 prototype models were being developed. So for the safety of the patient, whenever each model was being tested, first he was made to walk through the parallel bar, and then once he was being comfortable, then he was made to walk in the outer environment. And results through this was the socket comfort score was based on 11 point ordinal scale, and it turned out to be good. And functional mobility lies within the standard data of L test came upon like plus or minus 54.4. So discussion like two prototype models, as I've mentioned, like it was been checked for ML stability and mechanism for quick adjustability. In prototype model 1, amputee was walking in lateral trunk bending. Um, uh, the volume fluctuation in socket was not even, and translation motion could be seen between the socket walls, which made the amputee feel insecure. Like there was like translation motion between the biwall socket in the prototype model. So all these problems were being rectified in the prototype model 2, and the cons observed in the model 1 was rectified in model 2, and the subject's ambulation improved. However, the test was to be discontinued due to the breakage in the ratchet dial mechanism. Like you can see, this is the prototype model 2. And so the conclusion was of my study was the comfort of the socket was good, and the quick adjustability feature was achieved. However, the medial lateral stability was unaccomplished as the test had to be discontinued due to the flaw in the mechanism of the ratchet dial. Therefore, this can be achieved with a dual ratchet dial, which can better sustain the dual channeling load. And there should be some X-ray methods used to analyze the ML stability within the socket. And by remodeling the design with better channeling of the ratchet dial system, modifying the ratchet dial system with a metallic gear, and test run over multiple subjects can help achieving in the socket required for the subjects with limb volume fluctuations, and prevent prosthetic rejection rate. These are my reference, and thank you.
Thank you, Mr. Guru M. Do we have any questions in the audience? Thank you, Mr. Guru M, for your wonderful presentation.
Yeah, thank you.
Let's proceed to the next one. Our next presentation is titled Optimum Duration for Efficient Gait Training of New Transtibial Prosthesis Users, authored by Ms. Minakshi and Mr. G. Inian Balaji. Ms. Minakshi is a senior RCI certified prosthetist and orthotist, presently working with Mobility India Bangalore as assistant professor, PNO training department, with over 15 years of work experience extensively in clinical and teaching. It will be presented by RCI certified prosthetist and orthotist, Mr. G. Inian Balaji. Let's welcome him with a big round of applause.
Good afternoon, all who present here. I would like to thank you for the Mobility India to give the great opportunity to present my dissertation topic in this platform. And here, the topic of my dissertation is the optimum duration of for efficient gait training of new transtibial user. My guide was Minakshi, assistant professor in Mobility India, and myself. As we already know, the person who went for the amputation will have the will have the person with amputation regain the ability to walk again. You will face more problems to gain their walk. As we are a prosthetist, we give the prosthetic rehabilitation involves the provision of prosthesis and physical training to regain the balance and mobility. We will provide the processes, and the physical training will be like gait training, which will help the patient to adapt to the environment, to regain the balance, to reach the optimum weight bearing on the processes, and regain his gait pattern, and regain his ADL activities. A number of studies was investigated in different gait training methods, like overgrown gait training method, treadmill, anti-gravity, with different duration of section, where the studies were conducted in developed countries, where mostly in India, we are following the ICRC gait training, which will start with the optimum gait, weight bearing and to the advanced level. And where these studies are conducted with a different durations level, like 30 minutes, 40 minutes, for the gaps like 1 week, 2 week, 1 month and all. And there is still now, there is no study which to identify the gait efficiency, which is depends on the duration of the gait training. There is no study which belongs to this. Based on this concept, I suggest like 2 groups of patients will be studied with the same gait training, prosthetic gait training with 2 different duration, which will helps to identify how that duration will be depends on the gait efficiency. The study design was an experimental study design. The study subject was new transtable prosthetic user. The sample size was 16. The study setting was various rehabilitation center in Bangalore, Vellore, and Delhi. The source of data was offline and online. The sampling method was convenient consecutive sampling method. The data collections were the validated data collection form was there, which consider BBS, FSST, 10-meter walking test, and L test. The data analysis done by IBM SPSS after version 26, and the test which I was used is student independent t-test. The inclusion criteria were new transtable user, adult with age between 18 to 70, able to follow verbal instruction, well-healed residual limb to tolerate the process on initially more than 15 minutes, and medically stable. The patients who with no deformities or contracture on the amputate side or normal side. The exclusion criteria are knee flexion contracture, patient with amputation of any other limb limiting prosthetic gait training, and any other condition that limits the mobility like fractures or cognitive impairment. The methodology. The patient, the unilateral new transtable patient will come to them, and we will confirm the eligibility criteria according to the inclusion and exclusion criteria. And after the conveyance group, the researcher will split them according to the gender. According to the gender, they will split into group 1 and group 2, where the group 1, after splitting, the gait training will be started. The gait training for the group 1 will be 20 minutes of active gait training timing, and for the group 2, it is active 40 minutes of gait training timing. And this gait training duration will be like up to 1 week. Every day they will have the 20 minutes and 40 minutes gait training timing up to 1 week. And once they complete the gait training, the outcome measures will be taken, like for the group 1 and group 2. The statistical analysis done in between the group 1 and group 2 according to the outcome measures and the results. The demographic data of the study was, as I said, the researchers separated the group according to the gender, where in group 1, 6 male patient and 2 female patient in the group 2. The cause of amputation was trauma, mostly trauma, followed by the diabetes and Hansen disease and snake bite. The mean age of the total study was 58, and these are the age where the patients were participating in the study. And the result, this is the result which we found in the student impaired test, and this test were give the significant results for the study. We will discuss this one in the discussion. As this one is the first study which taken the impact of the gait training duration on new prosthetic users, whereas the previous studies were mostly focused on the gait training methods. There is no any gait training duration was followed till in those studies. In the studies, the 10-meter walking test, these are the outcome measures. The 10-meter walking test is for speed. I splitted the outcome measures like for the speed, mobility, balance, and stability. For the speed, I have taken the 10-meter walking test, where the patients group 1 took short time of 6.87 seconds, and the mean time was 8.92 seconds. The group 2 takes a short time of 5.46 and the mean was 5.78. The FFST for the stability, to check the stability, where the patients in the group 1 took a 8.92 and in the group 2 took 8.14. In our study, the patients in the group 1 were seen to complete the L test in short time as 14.92 seconds, and in the group 2 it took 24.11. In this group, the group 1 obtained a 48.50 and group 2 obtained the overall mean of the BBS. The outcome measures of FFT, intermediate walking test, L test, and BBS also show the favorable result for the patients undergone to the group 2 compared to the group 1. The difference was statistically significant in each domain, in the like mobility, stability, balance, and speed. The current study concludes that there is a significant difference between the gait training duration of the two groups and in stability, balance, speed, and mobility. As per the conclusion, as per the study, we can conclude the 40 minutes gait training was more efficient when compared to the 20 minutes gait training, and it suggests like if the more duration, if the gait training was have the more duration, the more efficient you will get the gait efficiency. And so the intervention group 40 minutes is sufficient and efficient gait training for the new transmissible user. The future scope of the research was the similar study was with, if the similar study with large size, it will be give a better results, and further studies can do with the more groups, like durations, like as I did in only 2 groups. If it is 3 or 4, we will find the exact duration for the gait training, which will help the patient to like if the bulk patient came to your center, we will it helps to provide a schedule, and it will give the clear cut like how much time it will take for the gait duration, and it will help for the prosthetist and physiotherapist to treat them for the gait training. This is the bibliography, and thank you.
Thank you very much, Mr. Balaji. Is there any questions to be asked?
Hello.
Hello.
Hello. Yeah.
Hello.
Mr. Mishra, we can hear you clearly.
Yeah, my question is nice presentation. All the 3 speakers have presented their dissertation very good. My first question is for this presentation. What is BBS? What are the parameters you have taken under your study for the BBS, and what is your recommendation for 10-meter walking test and FSST for the geriatric persons who are affected by the diabetes?
It's not clear. Sir, can you
I
repeat the
think-
questions again?
My question is that what is BBS? Means you have used this terminology, but nowhere explained this terminology in the slides. Are you getting my voice?
Sir?
Are you getting my voice?
No, sir, it's not clear. BBS.
Yeah, BBS. What is this BBS? You have not explained in your whole presentation.
Sir, BBS
Well-
is a outcome measure which taken for the which also taken for the old age people, and there is a study which the BBS was taken for the transmissible users also. The BBS is a Berg's balance test which will have contains 14 questions which related to the balance of the persons, like standing with the closed eyes, and obstacles taken from the ground, sitting, standing, like this. It will have a 14 questions in the BBS, and it's validated, and validity and reliability was done in one research, and it is good, and this outcome measure was, it shows like it is a valid and reliable in some articles.
My suggestion is it should be included in your presentation also. It is not there. That's why I have asked this. You have explained all the things, but you have missed or skipped unknowingly.
Okay.
It should be focused also.
Okay,
Okay,
sir.
thank you. Thank you.
Thank you for your suggestion, sir.
Thank you, Mr. for your suggestion. And thank you, Mr. Balaji, for your wonderful presentation. And this concludes our session for.
Thank you.
Okay, thank you, Mr. Sanyam, for chairing the session. So huge round of applause for him. So, now I would like to invite our next chairperson on the stage. So please welcome Mr. Dhanamini. So he is working as a clinical trainer, prosthetics and orthotics at Mobility India. So over to you.
Good afternoon, everyone. Thank you, Mr. Jivan, for giving this opportunity as a chairperson. Okay. The title of the title is Rehabilitation of the Pectoral Prosthetic Mobility Evaluation Questionnaire. An MS-based outcome measure tools for assessing mobility in the transtable prosthetic user. And the author are the Ms. Ritu Ghosh, Academic Director, and Mr. Riaz, Assistant Professor, Mobility India. And this is going to be presented by Mr. Ravi, Certified PNO. Please welcome the Mr. Ravi on the stage.
Good afternoon all. I'm Ravi. I'm MPO final year student from Mobility India. Today I'm going to discuss on REST validation of pictorial prosthetic mobility evaluation questionnaire, an outcome measure tool for assessing mobility in transtable prosthetic users. See, from morning we are discussing about various devices like insoles, transfemoral amputee prosthesis, transtable prosthesis. But how we will check with whether this devices is fulfilling their requirements or not? What we want to intend from that device? Is it is it doing that work properly or not? For that, outcome measures are required. There are various outcome measures for every different type of activity. Here I will discuss about a outcome measure that we newly constructed on transtibial prosthetic users. Outcome measure, a standardized instrument that can assist to quantify the current status and evaluate the change in health status of individual over time. But when we focusing on prosthetic mobility, there are so many outcome measures like a prosthetic evaluation questionnaire, locomotive capability index. But these all are standardized text-based questionnaires. And studies recent studies suggest that whenever text-based questionnaires are there, it can lead to less engagement, or sometimes it can act as a language barrier for the participants. Like it is not suitable, like everyone knows English. So sometimes whenever text-based questionnaires are there, it can be act as a language barrier for the patients also. In contrast, image-based feedback questionnaire listed several potential benefits such as more specific coverage, improved engagement, and encouragement also. Now, along with that, a report also published by ISPO in September 2021 that stated that till now there is no psychometrically tested outcome measure which incorporates question on activities that are more relevant to low or middle income countries like in India. So many activities like cross leg sitting, going to temples and praying places. These type of activities are not included in any outcome measure. And in Indian scenario or this type of scenario, these are very common activities we any amputee or any person will perform. So the aim of this study is to construct and validate an image assisted new outcome measure for assessing mobility in transtibial prosthetic users, comprising 12 items of already stabilized prosthetic evaluation questionnaire. Those are practicing in their clinical setups. They already know about prosthetic evaluation questionnaire. It is widely, most commonly used outcome measure with additional questions on cross-leg sitting, public transport questions. Now moving on methodology, study design for my is cross-sectional survey study, and study subjects were unilateral transtibial processes users, and study sample were known probability conjugative sampling, and sample size for my study is 40. Data collection was done through two different questionnaire. One is newly constructed pictorial prosthetic mobility evaluation questionnaire, or we can say PPMEQ, and another is already stabilized questionnaire, locomotor capability index. And the outcome measures for this study is reliability and validity. Data analysis was done for this study is with the help of WinStep software for RESH analysis approach. Now the sample selection criteria, the inclusion criteria for my study was patients can able to walk for 2 minutes, unilateral transtibial processes users who completed their rehabilitation period and prosthetic training program at least 6 months before the start of a study, no other physiological or neuromuscular disorders, or adult age, prosthesis is in good working condition. And exclusion criteria were presence of any cognitive function deficits, any condition that prohibited the prosthetic fitting use, and non-ambulation before lower limb amputation, bilateral, age more than 80 years, and other musculoskeletal disorders. Now this is a one flow chart that shows how my full study has been gone. First, I formulated my questionnaire along with a already stabilized questionnaire in pictorial form. Then I did pilot test with the participants and expert with their experts other experts review, and I revised that questionnaire according to feedback. Then data collection I have done in offline mode also and online mode also. And more than 7 states I covered all over the India with 40 participants, and further data analysis was done in WinStep software. So these are some sample images of my pictorial prosthetic mobility evaluation questions, like to walk upstairs, to walk downstairs. Here we want to constrain, like we want to reduce written content, means text-based content, and that's why we use responses also in pictorial presentation. Other examples are to sit down and get up from low chair, and to travel in public transport, bus or train. Like now moving on results. First of all, socio-demographic information of the participants, which include age. Mean age of my participants were 46-year age. After that, side of amputation, I use only unilateral, so only right or left, no bilateral patients are there. Then gender ratio. After that, employment. Then cause of amputation, in which 50% of amputees were due to any traumatic incidents. After that, second largest is due to diabetic cases. Then level of education. Then ambulatory activities performed with the prosthesis, like how much activity they did only with prosthesis. They are not using any other supportive devices. Then type of prosthesis which they are using, like endoskeletal prosthesis with Jaipur foot, or endoskeletal prosthesis with high activity foot, or such foot, like this type of. Now, moving on, main focus on reliability and validity. This data has been analyzed by RASH analysis approach in WinStep software, and reliability for my questionnaire was found, item separation reliability was found 0.95 or 95% with the item separation index 4.43, and person separation reliability was 0.9 or 90% with the person separation index 2.94. Now, moving on validity. Out of 14 questions, like 12 question already there and 2 question we included in that, 2 questions were misfitted, and because they didn't follow the criteria of RASH analysis, in which their mean square value should be in between 0.8 to 1.2, and that 2 questions are question number 13, ability to cross leg sitting, and question number 9, to in and out of the car. And here you can see their mean square values also. Here in both sides there is a different, like both values are more than 1.2. So that's why these both questions are misfitted according to my questionnaire. After that, focusing on construct validity. Like in starting, I told like data collection I have done with the locomotor capability index also. That is to stabilize construct validity, because locomotor capability index is already well stabilized outcome measure. And in Mobility India also, we have used LCI 5. I also use same questionnaire. And the scores of PPMEQ, I compared with the LCI, and the correlation coefficient found 0.79. And other two, I compare these correlate these scores of PPMEQ with 2 socio-demographic variables also. Number of hours the prosthesis worn per day, and the coefficient correlation is 0.55. And another is percentage of ambulatory activities performed with the prosthesis daily, and the coefficient correlation found 0.58. Now, for in last user feedback, okay, we made one questionnaire, we did the analysis, but how users, what they are filling that questionnaire, what they think about that. So we asked the 3 questions. First question is, this questionnaire is interactive to you, and the 97% responded yes. And next way is, this questionnaire can cover all your activity barriers, like basic activity barriers, walking upstairs, down and ramp and other things. And 90% responded that most of their activities have been covered by this questionnaire. And in last question, will you recommend this type of questionnaire to the use of assessing mobility to other patients also? And 95% patient respond like, yes, we will recommend this type of questionnaire to other users also. Now, in this current study have been used RASH analysis approach to evaluate the mobility of unilateral transtibial prosthesis user with the help of pictorial questionnaires. And result allowed us to choose that condensed set of items with excellent psychometric properties. Like psychometric properties are 3: validity, reliability, and responsiveness. So here I approach validity and reliability of that questionnaire. That 12 items comprising PPMEQ fit the RASH model. This is new approach to check reliability and validity of any questionnaire. Before that, we use retest reliability and other approaches. This one is a new approach for to check. And to the misfitting items, like to get in and out of the car, cross leg sitting, were removed. As it demonstrated, these items are poorly related to the questionnaire, and it can be various reasons. As we discuss with experts, and according to further studies also, it can be happen like if their patients conditions are different, this type of questions can be misfitted there. Now, PPMEQ also demonstrate a strong correlation with the LCI 5, that is already stabilized questionnaire, and moderate correlation with the 2 socio-demographic variables, time of prosthetic wear and use of prosthesis for ambulatory activities. In conclusion, that a RASH analysis allowed a development of new pictorial prosthetic questionnaire. And PPMEQ is a potential patient-reported outcome measure that can offer psychometrically sound evaluation of a prosthetic mobility in patients with lower limb amputation. Further researches are required, like we did only for 40 patients. Further researches are required to generalize this result to all over the population, to surge confidence in clinical use scale. Like now only we use only in Mobility India, and we approach this questionnaire. We need more clinical trials for approaching this. And other, like there are this approach, pictorial questionnaire approach, should be tried with other questionnaire also, like locomotor capability index and tapes also. We should try with that also, also the pictorial questionnaire approach. Thanks to all. These are all my references. Thank you.
Any question from the audience?
Hello. Okay, Ravi,
Yes,
in
sir.
outcome measures, you
Yes,
have
sir.
written your outcome measures is reliability and validity.
Validity.
But it is the property of any outcome measure, whether that taste is reliable or valid. Like,
Sir,
you have used PPMQ and LCI, locomotor capability index. So these are the outcome measures, and the properties, as I know, that reliability and validity are the properties. We are checking that one. So
sir, when we approaching any like clinical test, like for Balaji he did for gate training, on that time like PPMEQ and these are outcome measures. But when we are stabilizing these type of outcome measures, for that outcome measures will be validity, reliability, and responsiveness. In this study, I approaches only validity and reliability. Responsiveness part I didn't. We didn't follow that responsiveness. But whenever we stabilizing new outcome measure, for that finding that study, outcome measures will be their property, will be either it can be reliability or validity. And here we found both in like validity, I use both approaches. Rash analysis method also I use, and conventional construct validity approach also I use.
okay, so means that outcome measures have no any name like locomotor capability index. It is like only reliability and validity.
Yes, sir.
Means
Like
your
because,
outcome measures.
because I'm checking for me, I have to check outcome measures for outcome measures.
Okay.
Like outcome measures are already there, LCI and PPMEQ.
Okay.
For that, I have to check what are the outcomes of that. For that, for my study, outcome measures will be reliability and validity.
Okay. And about your sampling method, you have written non-probability consecutive sampling. Consecutive sampling is itself a non-probability sampling.
Yes, sir.
So why you are writing again non-probability in front of this? Better to write only non-consecutive sampling.
Okay, sir. Maybe next time I will.
Yes. Okay. And your image based was very good. Okay. That you have put some images instead of verbal or written instruction. Very nice. Okay. Thank you.
Thank you, sir.
Hello. Am I audible?
Yes, sir.
My suggestion, congratulations for this study. Lacking part, what I have noticed, there is no pictorial study during the gate training in the ramps or uneven surfaces. I
Sir?
think you have done, I think you have considered this point. I mean, whatever the gate walking pictures you have taken is on the ladders coming, going up and coming down. There is no pictures which advocates that you have done any study in the hilly area or uneven surfaces or ramps. First. Second one, what is your suggestion or your findings when you have studied on the numbers of the Jaipur foot and Sach foot? Is there any advantages you have seen? Which foot will be the beneficial for these type of studies or for this type of amputees? And the last, what are the socio-demographic terms which have you mentioned in your results? Other socio-demographic considerations you have not explained in all your in these PPTs. I think these are my suggestions. You should consider it, and when final dissertation or research paper will be there, you should elaborate on these points also.
Sir, as I have only 10 minutes, so I show only sample of images. These are only 4 images, but I made 14 images for all 14 questions.
Yeah.
And it include like to walk in confined space, to walk upstairs, to walk downstairs, then to walk up step hill or like a ramp and up, and then to downstairs also. After that, to walk in rainy area or uneven surface. After that, like to walk in, to get in out of the car, then to travel in public transport and cross leg sitting. So I use all images and I did study with all type of questions. But here I have less time, so I just show samples of all 4 images. Sir.
Okay. Thank you.
Thank you.
And other socio-demographic, what is means? What you I mean? You have used this term, na? Other socio-demographic data, or in this word has been used.
Sir, but like main socio-demographic variables, I use like a number of hour prosthesis worn per day. I use for construct validity. like how
Yeah.
much correlation is there for in between that process. And I found moderate correlation with the two questions like ambulatory activities and worn per processes worn per day.
Okay. Thank you.
Thank you, sir.
Thank you.
Thank you, Mr. Ravi, for wonderful presentation.
Thank you, Mr. Dhanamani, for chairing the session. And it was very nice interactive session. And we hope also after the break, same kind of interactive session we should see. So now we are having a short break. We are having a short break till 3:30, 3:40. So we will meet at 3:40. Thank you. So everybody kindly assemble here at 3:20 so we can start the session on time.
Hello.
Hello. ठीक है.